Good evening, everybody. The topic for today is cardiovascular outcome trials and GLP-1 receptor agonists impacting guidelines to practice. All of us know diabetes is a den of cardiovascular disease. Cardiovascular disease in diabetics occurs 10 to 15 years earlier, is 2 times more common than non-diabetics, and a major chunk of population of diabetics, almost 52 to 80%, succumb to a cardiovascular disease, mainly acute myocardial infarction. Diabetes shortens the lifespan by 6 years. If an AMI gets superimposed, the lifespan is cut short by 12 years. And therefore, for optimum management of diabetes, cardiologists and diabetologists should join hands. Cardiologists should try to learn diabetes and become cardiodiabetologists, and diabetologists should try to learn cardiology and become diabetocardiologists. Now, when we look at the pathophysiology of cardiovascular disease in diabetes, there are mainly two pathways. One, the atherosclerotic pathways, which produces myocardial infarction, stroke, and peripheral vascular disease, and the other pathway is heart failure. Both these pathways can result in cardiovascular death. But it is important to remember that 70% of deaths in diabetics occur due to acute myocardial infarction. And if we want to reduce this number of 12 years in a patient of diabetes with acute myocardial infarction and try to increase the lifespan of diabetics, the AMI has to be minimized. And indeed, GLP-1 receptor agonists are powered to decrease AMI in strokes in diabetic patients. What is the biggest message for cardiovascular disease in diabetes? The biggest message is you can die of heart attack even with a very good control with HbA1c of 6.5, indicating that good glycemic control does not prevent heart attack. What is very distressing is that diabetes and heart attacks are hitting young Indians. We have childhood obesity, childhood diabetes, young MIs, and isolated systolic hypertension in the young. And physical inactivity and consumption of high energy foods are important factors contributing to it. The second message is we should avoid hypoglycemia in diabetes because hypoglycemia is associated with increased cardiovascular morbidity and mortality. And hypoglycemia acts through diverse pathways. It may produce endothelial dysfunction, increases coagulability of the blood, produces inflammation, and produces sympathetic stimulation. And therefore, in diabetics, those anti-diabetic medications which produces minimal or no hypoglycemia should be preferred, like metformin, DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists. Point of interest is that anti-diabetic medications with BP lowering effects should be preferred. Every 1 or 2 millimeter rise or fall in blood pressure is very relevant because this translates into big transformation in cardiovascular morbidity and mortality because the heart beats 70 times in a minute, 4,200 times in an hour, and 1 lakh times in 24 hours. So even if the blood pressure is elevated by 1 or 2 millimeters, it will be transmitted to the whole cardiovascular system 1 lakhs every 24 hours. And this is the reason why small decrease in blood pressure translates into big reduction in cardiovascular morbidity and mortality. And in diabetic, drugs like SGLT2 inhibitors and GLP-1 receptor agonists, they decrease blood pressure. I'll be giving my talk in 3 parts, and the first part is role of GLP-1 in maintaining normal glucose levels. All of us know, despite availability of numerous treatments, diabetes still remains a challenge. Diabetes remains the 9th major cause of death globally. 50% of diabetes with type 2 diabetes present with microvascular complication, 20% present with macrovascular complication, and 25% of diabetics have diabetic kidney disease. Now, when we go down the memory lane of GLP-1 receptor agonists from venom to clinical benefits, for the last 32 years, it was first isolated from the Gila monster. 1992, there was isolation of hexadecitin 4. 2005, first twice daily GLP-1 receptor for diabetes was isolated, that is exenatide. And 2010, we have the first once daily GLP-1 receptor agonist approved for diabetes, that is liraglutide. And 2012, we have the first once weekly GLP-1 receptor agonist for diabetes, that is semaglutide. And 2014, we have the first once daily GLP-1 receptor agonist for obesity. And 2016, we have the first GLP receptor agonist plus insulin combination. And 2019, we had a new therapeutic innovation of oral semaglutide, which has been approved by US FDA. Now, all of us know the incretin effect is diminished in patients of diabetes. On the left side of your screen, you can see the incretin effect in individuals who are healthy, and on the right side, you can see the incretin effect in diabetes, which is decreased. And when we use these new agent GLP-1 receptor agonists, you have an increase in glucose-dependent insulin secretion and an increased suppression of glucose-dependent glucagon. Both these contributes to diminution in hyperglycemia. And so what is the difference between the native human GLP-1 and the liraglutide? As you can see, there are two changes which has been done to create this new molecule. The first is a fatty acid is acylated to lysine at position 26. And the second change which has been done is lysine at position 34 is replaced by arginine. And as a consequence of this, this new drug continues to act for a longer time and produces therapeutic effects. Now, this new molecule has a panoply of cardiovascular benefits, as you can see on the slide: decreased inflammation, increased glucose uptake, ischemic injury, decrease in the heart, improved LV function, slight increase in heart rate, decreased inflammation in the vessels, endothelial function improves, vasodilatation, plaque stability, increased blood flow in the vessels, decrease in smooth cell proliferation, platelet aggregation, and it produces protective effect on several organs. Besides cardiac protection, if you look at the kidneys, there's increased natriuresis and increased diuresis. Coagulation system, there's decreased coagulation, decreased postprandial lipids, decreased blood pressure, decreased body weight, decreased inflammation, and by its glucose-dependent action, it produces increase in the insulin secretion and decrease in the glucagon secretion, and also has a favorable effect on the beta cells. The apoptosis is decreased. So it reduces inflammation, increases plaque stability, and prevents progression of atherosclerotic plaque. So let's look at the second component of my talk. What are the cardiac benefits of anti-diabetic medication, and what lessons we have learned from the cardiovascular outcome trials, and we'll also see a case of diabetes. Now let's see this Anisha, who is a 50 years old female, height 166 centimeters, weight 88.5, obviously overweight, BMI 32, obviously more, occupation lawyer, and she has diabetes duration of 12 years. If you look at the total cholesterol, it is 213, which is higher, HDL 47, diastolic blood pressure 81 by 140, slightly higher, EGFR is 60, family history of diabetes, non-smoker, and so far as exercise is concerned, there's no aerobic or resistant exercises. The treatment she is on is metformin 2000 milligram twice daily, 120 milligram of glycoside, sitagliptin 100, and 25 milligram of hydrochlorothiazide, aspirin, ACE inhibit. She is a busy law practice and leading to unpredictable schedule, obviously, and diet. Blood sugar is variable and generally uncontrolled, and particularly after meals. She was just initiated on antihypertensive drugs like HC hydrochlorothiazide, and patient is obese and has an acute myocardial infarction few years back. Now, when we look at this patient, she has a long-standing diabetes, family history of diabetes, history of myocardial infarction. She is hypertensive. She has a busy as well as a sedentary lifestyle, obese, unpredictable dietary habits, dyslipidemia, multiple OAD failure, and she needs prevention of worsening of the cardiovascular disease. Now, this is a patient with a high CV risk, a very bad cardiometabolic profile. She is hypertensive, she is obese, the BMI is more. She is not on high intensity statin, which she should be because she has already suffered from myocardial infarction in past, and she is not on any anti-diabetic medication which can decrease MI and stroke. She has already suffered myocardial infarction in past, so there is urgent necessity to minimize MI and stroke in future. And if you look at such patients in clinical practice, what is usually advised by many physicians is they will advise insulin at this stage, which is not appropriate for a panoply of reasons. It will further increase the weight. There will be no decrease in blood pressure, hypoglycemia, and no protection against ASCVD. We'll see later on what would be the optimum therapy for such type of patients, which are not uncommon in our day-to-day practice. As already told you in the past, whenever we are trying to minimize cardiovascular disease or in fact selecting anti-diabetic medication for treatment of hyperglycemia, special focus should be on drugs which has minimal or no hypoglycemia. And if you look at the drugs which have low hypoglycemia potential, TZD, but it has a lot of side effects, AGI, again, lot of GI side effects, DPP4, it is low hypoglycemia, but it does not decrease cardiovascular disease. The two drugs which have low hypoglycemia potential and also provide cardiac protection are SGLT2 and GLP-1 receptor agonists. Insulin, of course, has a very high potential for hypoglycemia. The second thing which we select when we are treating patients of diabetes is to see that our patient, besides control of his glycemia, also has ASCVD reduction and also heart failure and CKD reduction. And as you can see, these two sets of drugs, SGLT2 and GLP-1, are the ones which provide cardiac protection, renal protection. And the third thing, because treatment of diabetes is almost a lifelong process, therefore drugs which produces minimal or no side effects should be the choice. And if we look at the spectrum of anti-diabetic medications, I think most of the anti-diabetic medications have some side effects, whether it is sulfonylurea, TZ or AGI or DPP4 are very well tolerated. SGLT2 was also genital urinary infection. Insulin also has side effect. GLP-1 RA is another molecule which, except for initial nausea and maybe vomiting, they do not have any side effects in the long run. So how do we compare the incretin-based therapy? We have a GLP-1 RA and a DPP4 inhibitor. GLP-1 RA, all of us know, is a subcutaneous injection. DPP4 is an oral medication. And the GLP-1 RA resists degradation by DPP4 enzymes for reason I've already told you. And the DPP4 inhibitors, they inhibit the DPP4 enzyme, and much higher levels are reached with GLP-1 RA compared to DPP4, where it is a weak drug, and high pharmacology levels are reached with GLP-1. Now, when we look at as to what is an ideal anti-diabetic medication, it strikes to us that drugs should have good glycemic control, minimal hypoglycemia, should try to decrease weight, preserve beta cell function, and can be used in renal and hepatic impairment and have minimal or no side effects. And when used, it should provide CVD risk reduction. So let's look at some of the cardiovascular trials. Now, liraglutide initially was tried for glycemic control, and as you can see in this slide, it produces very good glycemic control. And then we had the CV outcome trial, the leader trial, and this is the leader trial which showed fantastic results. This was done in 9,000 patients. Liraglutide, the dose was gradually built up from 0.6, 1.8, and this was compared to the standard of care. And this was a primary plus secondary prevention trial, and look at the results. The primary endpoint in atherosclerotic MACE, cardiovascular death, MI, stroke decreased by 13%, which was statistically significant. And look at the cardiovascular death, decreased by 22%, the only GLP-1 receptor agonist which decreases cardiovascular death by 22%. Fatal strokes, non-fatal MI, there was a numerical decrease, but not statistically significant. And when we look at the all-cause mortality, again, a statistically significant 15% reduction in the all-cause mortality. And when we look at the hospitalization for heart failure, a 13% numerical decrease, not statistically significant. The message is all hazard ratio with GLP-1 are to the leftwards, they are to the left of the midline, so they do not harm any of the components of cardiovascular disease in diabetics. Everything is to the left of the midline. And when we look at the other parameters, there was limited difference in the HbA1c maintained throughout the trial, as you can see on the graph. Hypoglycemia was much less with this agent, and there was also a statistically significant greater weight loss, as we always desire in these patients. And there was a 16% reduction in the microvascular events with LIRA, and microvascular benefit was driven by 20% reduction in nephropathy. And when we look at the glycemic control, as you can see in this slide, LIRA scores over all anti-diabetic medication in isolation or combination. You can see these blue bars. The glycemic control is much better with LIRA than with other agents. And as I already talked in the beginning, it produces reduction in blood pressure, and any reduction in blood pressure is of paramount importance in the long term for decreasing atherosclerotic morbidity and mortality. It also favorably alters the lipids. You can see the total cholesterol is decreased, the LDL cholesterol is decreased, the triglycerides are decreased. And when we look at the biomarkers, the PI1 is decreased, the BNP is decreased, and the HSCRP is also decreased. And so it has a panoply of anti-atherosclerotic effects and CV benefits. You can see it acts on the vessel wall directly and indirectly. It improves endothelial function, decreases vascular smooth muscle activation, decreased proliferation, decreased inflammation, decreased lipid accumulation, and by all these mechanisms, it decreases blood pressure, decreases weight, and decreases HbA1c. It is a panoply of benefits on the myocardium. It improves the infarct size after ST segment elevation. Liraglutide improves myocardial salvage index and reduces infarct size. It reduces reperfusion injury in experimental animals. There's a greater decrease in LV ejection fraction with liraglutide compared to placebo in patients with STEMI undergoing PCI. And incretin therapy improves indicator of plaque stability in patients with diabetes. There's also an improvement in the ejection fraction. And now let's look at how this new agent impacts the guidelines and our clinical practice. Now, when we look at the CV outcome trials, you can see several trials of GLP-1 receptor agonists. The LEADER trial, which was carried out with liraglutide, the SUSTAIN trial, which was carried out with semaglutide. Then we had the REWIND trial, which carried out dulaglutide, and we had the HARMONY outcome trial, which was carried out with albaglutide, and the PIONEER 6 with oral semaglutide. All these trials have been positive trials. The only negative trial has been ELEXA, which was conducted with a short duration of action of GLP, and the EXCEL trial narrowly missed the p-value. Now, when we look at the cardiovascular risk reduction in diabetes, we have two components. A component of atherosclerotic cardiovascular disease, which we term as the pipe effect, and the component of heart failure, which we term as the pump effect. Now, if you look at the SGLT2 inhibitors, they are a panacea for heart failure. They decrease hospitalization for heart failure.
in individuals who are at risk of it, and the DAPA-HF trial showed they also improve outcome in those individuals who have already decreased heart failure with reduced ejection fraction. Trials of SGLT2 inhibitors in heart failure with preserved ejection fraction are ongoing, and it is speculated that these trials may also come out positive. EMPA and the EMPERAGE showed a reduction in cardiovascular death by about 38%, 3-point MACE were decreased by 13%, and the effect on atherosclerotic complications were not observed. So no MI decrease, no MI, and no stroke reduction. CANA showed a positive 3-point MACE, decreased by 13%, but the other effects were not seen because CANA has a mixed population of primary and secondary prevention, and the DAPA trial has large number of primary prevention and lesser number of secondary prevention, did show a benefit in the cardiovascular and hospitalization for HF. But the subgroup analysis done in patients who had already developed MI did show the reduction in the 3-point MACE. Now, this is an overview of all the GLP-1 RA trials. When we look at the liraglutide, right on the top, cardiovascular death is decreased by 22%, 3-point MACE is decreased by 13%. When we look at the semaglutide, again, this is a positive trial, the 3-point MACE is decreased by 26%, and stroke is decreased as much as 39%. When we look at the semaglutide, this is again a positive trial and showed nearly 50% reduction in the cardiac vascular death. Lixisenatide was a negative trial, Lixa, because the GLP used has shorter duration of action. And the Excel trial, as you can see, narrowly missed the people. The alpaglutide is the only trial which showed 25% reduction in MI, and a 3-point MACE also decreased by about 24%. And the dulaglutide, which is the last trial to come out positive, again, a 12% reduction in the MACE and also a reduction in the non-fatal MI. So if you exclude 1 or 2 trials, all GLP-1 trials have shown positive CV outcomes in terms of reduction in the atherosclerotic events. They numerically decrease hospitalization for heart failure, but they're not the agents for HF. When we look at the problem of the pump failure, it is SGLT2 inhibitors which are the drug of choice, and diabetics can have this heart failure problem either because of an atherosclerotic disease due to myocardial infarction, or because of diabetic cardiomyopathy or hypertrophy and fibrosis because of hypertension or increase in the stiffness. And this pump problem is taken care by SGLT2 inhibitors, whereas the vessels problem is taken care by the GLP-1 receptor agonist. So we have 2 different types of agents. If you want to target heart failure, it is SGLT2. If you want to target the atherosclerotic complication, it is GLP-1 RA. Now, what do the guidelines say? Now, there has been revolutionary change in the guidelines. For several decades, all guidelines were following the glucocentric approach because we did not have any anti-diabetic agents from the conventional group which could decrease cardiovascular events. From 2018 onwards, both these agents have been put on the guidelines, and they are heading all current diabetes guidelines, the SGLT2 inhibitors and the GLP-1. So if atherosclerotic cardiovascular disease predominates, GLP-1 RA is the first choice, and we are not able to use, you can use SGLT2 inhibitors. If heart failure or CKD predominates, SGLT2 are the first choice provided eGFR is adequate, and if they cannot be used, you can use GLP-1 RA. If hypoglycemia is a concern, we have already talked, SGLT2, GLP-1 are good agents, TZD is also good, but has problems because of side effects, DPP-4 are also. And we've also talked the importance of reduction in weight, and again, GLP-1 and SGLT2, both are good agents, and if cost an issue, you can use cheaper agents. Now, prior to 2018, both these agents were recommended only for established ACVD, established CKD and heart failure, but 2019 onward, the ESC and the ADA 2020 have recommended these agents not only for patients with ASCVD, but also who are at high risk of developing ASCVD, heart failure, or CKD. So that is the major change from 2019 to 2020. So for several decades, we were following the glucocentric approach, trying to minimize hyperglycemia, but it did not benefit cardiac complications. And as we said, 2018 onward, with these two new agents, we have started targeting the atherosclerotic cardiovascular disease, the CKD, and heart failure. And all these agents have emerged as a panacea for CV risk reduction and also for reducing CKD. And the diabetic guidelines, which were merely glucocentric, have now become cardiocentric and also become nephrocentric. And again, these agents currently from 2019 onward, they are used for primary prevention as well as secondary prevention, and never in the history of diabetic guidelines, cardiology was never given so much importance. And now cardiology is heading the guidelines, all diabetes, whosoever guideline you open, right on the top, there will be cardiovascular risk reduction, heart failure reduction, ASCVD reduction. So cardiology has now hit the diabetes guidelines after many, many years. Now coming back to this lady whom we had talked is a very high risk case. Now if the most appropriate choice for this agent is a liraglutide, that is Victoza, you can start with 0.6 milligram and gradually build a dose 1.2, 1.8, and when this is done, the glycemic control is much better. You can see FPG has become 108 from 130 after 6 months. The post-breakfast has become 159 from 208. HbA1c 7.9 to 6.5. Body weight from 88.5 to 83.7. So, in summary, all of us know GLP-1 receptor agonists are wonderful agents. They reduce systolic blood pressure, inflammation, weight, lipid level. They produce improvement in the risk factor associated with risk of adverse cardiovascular outcomes. And GLP-1 therapy is associated with lower incidence of severe hypoglycemia. And this exploratory data suggests that GLP-1 receptor agonists may modify the progression of atherosclerotic vascular disease. Now, because we have SGLT2 agents, which are the agents for heart failure and for CKD, the GLP-1 are agents for atherosclerotic complications. Therefore, a plea was made, why not combine both these agents, and then we will have a comprehensive cardiovascular reduction. Now, if you combine both these agents, what will have? Besides better glycemic control and minimal hypoglycemia and better cardiometabolic, you will have a comprehensive CV risk reduction in terms of reduction of atherosclerotic complication, less MI, less stroke, decreased heart failure, and improvement in CKD. But the problem with this is that GLP is an injectable therapy, so many patients may not prefer an injectable therapy, and some patients in these GLP-1 trials were on this combination. So we have this new molecule, the oral semaglutide, which is an innovative molecule of the Novo Nordisk. This can be given orally and has shown a fantastic result in the Pioneer 6 trial. As you can see, cardiovascular death decreased by nearly 50%, and all-cause mortality nearly decreased by 50%, and non-fatal MI, there was the cardiovascular non-fatal stroke was also decreased by 26%, and this can be given orally. You may start with 14 milligrams, and then, so if you want to combine both these agents, the preference would be an oral semaglutide and SGLT2 inhibitors, and that would be palatable to large number of patients. And I am aware that this molecule may be launched by next year or no, but the final answer will be given by the Novo Nordisk. But the biggest problem with Lira or with other GLP-1A is a wonderful molecule, as we said. It produces cardiovascular risk reduction in terms of atherosclerotic complications, MI and stroke, good glycemic control, minimal hypoglycemia, weight reduction, BP reduction. But is highly underutilized. In India, utilized only in 1 to 2%, even in the West, Canada, USA, only 10% or so, UK again 10%. So what are the reasons? And let's see how we can improve the utilization of these wonderful molecules. One of the barriers which comes is a cost. Patient says that this is cost. And when we look at the benefits and the harms if you do not use liraglutide, now if you do not use liraglutide, what can happen is a agent which prevents MI in stroke. Now if you develop an MI, the pre-hospital mortality is 25%, and this has stayed at this level for so many decades, because in India we cannot check the pre-hospital mortality. Patient develops a VF or some other problem, 25% will die before reaching the hospital, and if an early family member dies, you can imagine the harm that is created. The cost of liraglutide is no comparison to the harm. Many patients of MI have sudden cardiac death as the first presentation. The in-hospital mortality, even in the best center, PCI dedicated center, best interventional cardiology, is still 4 to 5%, has dropped from 10-15% to 4 to 5. The cost of angioplasty is 1.2 lakhs or maybe more. And if the patient is not able to reach a PCI capable hospital because the diagnosis is delayed, he considers it to be a GI disorder, or if an interventional cardiologist is not available, then there are chances that you may develop a left ventricle failure, and in the long run you may require an ICD if the left ventricle ejection fraction drops less than 35%, or even a CRT. And if you undergo an angioplasty, you have to have a DAPT for 1 year minimum. And if you are a DAPT, suppose you develop bleeding, it's a problem. If you require emergency surgery in the first 3 months, very problematic. You are in a dilemma whether to stop DAPT, or the surgeon will say stop it, and if you stop it, there are problems of stent thrombosis. If you require an elective surgery during this period, again this is a problem. You met with an accident, there will be profuse bleeding. So MI prevention is of paramount importance. If a drug can prevent MI, it is a great blockbuster. The cost of liraglutide comes in no way. Looking at the harm if you get an MI, MI is a very deadly disease. Even in the best of the centers, is still the very common cause of cardiovascular morbidity and mortality. And even if you are in the best hospital, there could be problems. So best thing is to prevent an MI, and if a drug is there to prevent MI, you should use it. The second problem is stroke. Now again, if you develop a stroke, you may be crippled for the whole life if the facility of lytic therapy or carotid endovascular therapy is not available in the vicinity, because the window period is very short, 4.5 hours, so it has been extended to the endovascular surgery. So prevention of MI, prevention of stroke are indeed great achievements of this drug, and one of the reasons why cost comes in way of its increased use, the patient is not explained the benefits of these. MI and strokes are deadly diseases, and what I feel is it is the general practitioner, the family physicians, which are not aware of all these benefits and harm, because whenever you prescribe a lira, the first question a patient asks is to his family physician. If the family physician is not able to reply, the patient is not going to take a drug or put a book question. Whether this patient may be a VVI, chief minister, governor, anybody, even the president we have seen, they will always ask, I am prescribed this drug, should I take it or not? If the physician, if the family physician keeps mum, again, this creates a big question mark on the utility of drug. So what I feel, the benefits of lira and the harms of not taking lira should be widely percolated, not only amongst the high cardiologists, diabetologists, nephrologists. It should percolate. They may not be prescribing, but they should be aware that if somebody asks, I've been prescribed this, should I take? He should not be mum, he should say, yes, this is a very good drug. The second limitation or the barrier is that this is an injectable therapy. Now again, we will try to look at, will you prefer a single daily injection of lira, or will you like to have multiple oral drugs? Now if you use this agent, it produces a good reduction in HbA1c with minimal or no hypoglycemia. There is reduction in weight and blood pressure, which we desire. No need of frequent blood sugar monitoring, unlike insulin. Single daily injection prevents heart attacks and strokes. No side effects except nausea at the time of initiation. which can also be minimized by taking it on empty stomach using pantoprazole and slowly trying to build up the dose. If you don't use this agent, there is a risk of hypoglycemia, weight gain, frequent monitoring, no protection against heart attack and stroke, and protection against heart and stroke indeed are very strong benefits of these GLP-1 RA agents. So thank you very much for your kind attention.
Thank you, sir, for such a wonderful lecture. And I think the way you elocuted what is the actually difference between value and cost, the value that we get with liraglutide or GLP-1 RAs as opposed to the cost that everyone thinks about. It was really overwhelming for all of us. And surely we all have learned quite a few with you. Now, I'd request the participants, if you have any questions, you can click on the chat box and you can type in your questions, or maybe you can unmute yourself and you can ask questions directly to Manurya, sir. And sir, before we get all those questions, I think, sir, the way you explained that every 1 mmHg or maybe 2 to 3 mmHg reduction in hypertension that we get with these drugs, that will go a long way based on the number of times heartbeat in a day. So, sir, is it actually affects, or does this thing actually get converted into clinical benefit in your practice, sir? What is your...
See, the usual physician or practitioner often may not pay attention to 1 or 2 or 3 millimeter. But if you look at the meta-analysis or trials, every millimeter blood pressure reduction translates into benefit. So this is very, very important. 2 or 3 millimeters are very useful.
I think Dr. Mansukh Shah is unmuted and Dr. Asha has raised her hand. I'd request first to take questions from Dr. Asha and then we can move on to Dr. Mansukh Shah. Dr. Asha, you can please unmute and you can ask your question. Dr. Asha, there's a mic button on your screen. You can unmute and you can ask your question directly to sir. I think there's some technical glitch over there, sir. I think Dr. Mansukh Shah wants to ask some question. He has unmuted recently. So, sir, if you have any question, you can unmute yourself and you can ask directly to the sir. And I request all the participants, whatever you have questions for Dr. Manurya, sir, you can click on the chat box and you can share your questions with us. I think
they can write the question if the mic is not being unmuted.
So you can type in the questions. Meanwhile, sir, while we are trying to get over this technical glitch, I have few questions for you.
Yes.
Sir, GLP-1 RAs have been in India for past 10 years or so, and we have seen a paradigm shift, or revolutionary changes in the guidelines. What you have explained post 2018. But in spite of all these evidences and the guidelines, we don't see so much of acceptance. So where are we going wrong?
See, I told you, you will be the winner if anybody is asked a question, how is GLP-1? If at the present state of time you ask physicians, practitioners, many of them may be mum. So wide dissemination of its beneficial effects should be across the board. They may not, you may not be contacting only the super specialists. It should be right up to the grassroots. They may not be prescribers, but they would say, yes, it is a good drug. If you want to win the majority should speak about your praise of the drug. So that is the reason. I have seen many, if you ask general physicians, practitioners, and I already told, even a VVIP will always ask his permission. I have been prescribed this drug, how is it? If the practitioner or his family physician keeps mum, he thinks that something is wrong. So,
Yes.
whatsoever it should be widely disseminated from 2 points of view. One, the benefits, and secondly, if you do not take, what is the cost involved if you develop an acute myocardial infarction, what is the cost involved if you develop a stroke, and what is the loss if you develop both these complications. The loss is immense, it's irreparable loss. The cost is minimal when you compare to the loss, and if the life is lost, I think there could be no comparison to any cost. When an angioplasty costs 1.52 lakhs and there will be other costs involved, the cost of result is negligible. And another thing which is important is when you are told that this is an anti-diabetic drug, the patient takes some oral tech, he may take sulfonylurea. Why should I take liraglutide to control my blood sugar? Let me take sulfonylurea, very cheap drug, and my blood sugar will be controlled. You have to emphasize that this is not only anti-diabetic medication, the benefits are there on multiple scores. CVA is prevented, MI is prevented, then weight is reduced, so many things. All other medications which are cheap have harmful effects also. So the patient usually has a psychology that he compares what is his glycemic benefit with lira compared to sulfonylurea or whatever, TZ or whatever. And he finds I take my blood sugar has come. Most of the diabetic patients are glucocentric. They spend whole lives in measuring blood sugar throughout a life and don't bother. And we see most of the patients which are referred to us, they have MI, they have unstable angina. This glucocentric love for the patient of diabetes should also be minimized. They must be, this would be done by an education program that diabetes is a disease of glucose in simple words, yes. But more important than that is your cardiovascular risk reduction, your strokes reduction, and your kidney reduction, which is not merely by control of glycemia. We have agents which decrease CKD progression and decrease the trajectory of progression of GFR. They slow down the progress of GFR on top of glycemic control. If you use this, for example, SGLT2. So mere glycemic control is not self-sufficient. It is very important. It is mandatory. But you have to have other aims also for treatment of diabetes. The patient education is lacking in vast majority. Even an educated patient thinks, what is this diabetes? What is my blood sugar? What is my blood sugar? Every day is bothered about. He's not bothered about his MI because he doesn't know that MI can now be protected. His stroke can be protected. And he's at high risk of it. But he always thinks blood sugar, and that is the story. That is one of the other reasons.
Thank you, sir. Thank you, sir. I think it is a time to reclassify these drugs from being anti-diabetic medication to cardiometabolic drugs. I think that is the need of ours. And sir, one follow-up question for this. It seems Association of Cardiologists, EAC, AHA, they have gone one step ahead from Diabetes Association in even recommending GLP-1 RA as a first-line therapy, even ahead of metformin, if the patients have high risk for ASCVD. So, sir, so what has made this change? How come cardiologists are more accepting towards the benefits of GLP-1 RA as compared to the Diabetes Association?
See, the answer to this is, suppose I ask you, what is your aim in treatment of diabetes? You will say, I want to improve the quality of life, I want to increase the longevity of life. So you want to add years to life and life to years. And which drug will do this? Obviously, both these agents, GLP-1 and RA, they decrease and we are very proud of this time with anti-diabetic. They will decrease this 12-year number. We say diabetes premise, your lifespan is decreased by 12 years. After few years, we'll say 12 will be scrapped and you'll have a new slide with 10 years, 9 years, and so. So if you use these agents, you are increasing the longevity of life. Metformin is unique in the sense that it is the only drug which is most potent for decreasing hepatic glucose output. So after the use of these drugs, if your hepatic glucose output, insulin resistant at the level of liver and the skeletal muscle, metformin is right on the top. So ideally, metformin should also be combined, because what is our aim in treatment? Target insulin resistance, which is best targeted by metformin, targeted incretin defect, which is best targeted by GLP-1, target renal defect, which is best targeted by SGLT2. And if you use all these three combinations, you are hitting at most of the components of the ominous octet of Dr. T. Frenzo. So if you analyze, you're hitting most of the components. So metformin we will still like to use, because it's the only drug which targets insulin resistance, and insulin resistance is the number one pathophysiological defect in diabetes. So metformin, although the guidelines recommend it, but from the glucocentric view, this may be a necessity.
Thank you, sir. Thank you for that, elucidating how we can actually combine all these drugs and have the maximum benefit in terms of cardiometabolic outcomes. What should be the aim of treatment of any patient with diabetes, because as you have elucidated, they have a high risk and almost 12 years of life loss. Sir, one more question. There is a misconception amongst, I think, physicians and even patients, that people consider GLP-1, especially liraglutide, as a weight reduction molecule. And this is unrealistic expectations, but people tend to forget the benefit that it is offering. So how should we communicate this aspect to patients and even approaching primary care physicians?
See, liraglutide, I think you are aware, it's a 3 milligram dose, which would be for weight reduction. If you want to achieve weight reduction, it is semaglutide which is most potent. It produces reduction by almost 17%. So weight reduction is one of the benefits, but the greatest benefit is stroke and MI. I think somehow you have to disseminate the knowledge. What I see, a cardiologist goes and attends a cardiology conference, a diabetologist goes and attends a diabetologist. There is no cross connect. So unless these mingle, they mingle very uncommonly. We always organize cardiodiabetology conference. We want to learn from the diabetologists and they should learn from the cardiologist. Most of the conferences anywhere, that's why we also organize cardiometabolic conference. Because unless you are connecting each other, you will not be able to. So a diabetologist cannot tell us what are the harms of acute myocardial infarction. If you ask what are harms if I get a myocardial, he will not be able to tell us. The harms of developing myocardial itself is a most, what I should say, biggest complication of diabetes. It can ruin the whole family. So that should be the problem. Weight reduction, this is being used, and the best results are with semaglutide.
Thank you, sir. I'd just like to mention that yet as of now, we don't have Indian approval for liraglutide 3 milligram or we would be sure launching these drugs soon in India. But as of now, we don't market these drugs in India. But very soon, these drugs will be marketed in India. And as sir has said, maybe it is a time for a collaboration of endocrinology and cardiology to have the maximum benefit in terms of patients' outcome. Because somewhere patients are the one who are losing this battle because there is not enough collaboration. So thank you, sir. I think this is one of the most important.
The other benefit of GLP-1 is, yes, although it's not, it is also benefiting NASH patient, which is rampant in diabetes patients. So work is going in across. In future, you may see it ascending. So that will be an additional advantage, because NASH itself is a very distressing complication of diabetic patients, and large number of diabetic patients go on having NASH.
Yes, sir. So I think when we discovered GLP-1, we were also not aware that what all benefits we can expect out of it. And now we can see it is expanding, ever expanding, be from cardiology, be from nephrology, be in neurology also, sir. We have seen some benefits in Alzheimer's also, NASH also. But all those trials are currently going on, and we don't have label approval for these drugs as of now. It is still under evaluation. The research is definitely going on, and it is positive outcomes, whatever we have seen. Sir, I think if you don't have any further questions from anyone,
it is still in the category of a wonder drug and continue to surprise us, and I hope will continue to surprise us in future, as you told.
Sir, just one more question. What I have got is, what is your view of GLP-1 RAs and in terms of heart failure?
See, in terms of heart failure, SGLT2 is the winner. It has shown numerical decrease in heart failure, but it is SGLT2, SGLT2 and SGLT2. And for CKD also, it is SGLT2. Because SGLT2 is powered to change the trajectory of CKD. It produced when the first revolution came in 2001 when RAS blockers. Prior to RAS, the decline in GFR was 10 ml per year. 10 ml GFR used to decrease per year. When RAS came, it was decreased to 4.5 or 5. And now when SGLT2 is decreased, it has decreased by another 50%. So it's still 1.58 ml GFR decrease per year. We do not have at the moment approved drug, but there's a very interesting trial coming with non-steroidal MRAs, which I'm told is positive, and the drugs is going to be presented at the nephrology meeting in US this year. And so with the third drug, we will have further benefits of CKD. But for heart failure, it is the beauty of GLP does not harm, does not harm, does not harm. Benefit, benefit, benefit. That is the beauty. SGLT2 can harm also, other drugs can harm also, but GSP is a special drug. Benefit, 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 no harm.
Sir, one more question. If you look at the trials of statins, they were mainly against placebos, and they have definitely shown lots of benefit. But when we look at even at leader trials, it was compared to standard of care where more than 70% patients are already on ACE, ARBs, and other cardioprotective drugs, and still we were getting the benefit. So is it the time that we have started addressing the residual risk, which has been well spoken but never actually been addressed in the terms of treatment of patients with diabetes along with cardiovascular disease?
It indicates the power of GLP-1. If a drug is producing on top of all standard therapy, antiplatelet, ACE, MRAs and other statins, it means a very powerful drug. Because to get a benefit on top of all standard therapy these days is difficult because so many standard drugs they produce beneficial effects. So it speaks the power of the drug, how powerful it is to decrease the cardiovascular. It can decrease on top of statins and other drugs. So that indicates the power of the drug.
Thank you, sir. I think that was wonderfully answered. And sir, before we close this meeting, would you like to share some of your thought as to about GLP-1 RAs and what should be the future way forward with GLP-1 RAs?
I think the future way forward is education, education and education. Not only to the patients, to the cardiologists, to the nephrologists, to the physicians, to the practitioners. It is lack of education and lack of dissemination of the beneficial effects which are not increasing its utilization rates. Cost, I think this is not that much costly that it should come in way. People are not aware of its beneficial effect. When you can get an angioplasty 1.5, 2 lakhs, where is the cost of lira? So I think the beneficial effect has to be disseminated widely amongst the general public also. Then only, so that somebody says, what is lira? Yes, I know what is lira. When we prescribe lira, he thinks, what is my reduction in glucose? Sulfonylurea produces greater reduction than this. I take sulfonylurea, I take insulin, my blood sugar is controlled next day. So this is not a sugar reducing drug. It has actually it is a atherosclerotic drug or a cardioprotective drug or a cardiovascular protective drug with beneficial effects. It is not an anti-diabetic. That should be the goal, because if you say anti-diabetic, the meaning is conveyed that it is blood sugar reducing drug. These effects are secondary, should be educated. The primary effect is there. So do you want to decrease MI stroke? Yes. So what did you do, Lera? Do you want to decrease blood glucose? Then say, now I have A to Z choice. And he'll ask his family physician, he says, you take sulfonyl urea, T-Z, your blood sugar. So it should be impressed, this is a drug for heart attack and stroke prevention. If you say glycemic control, the glycemic control with insulin, others is so quick. The glycemic control with GLP is very slow. It is good, slow and steady, but it is slow. The patient should be very clearly told that this is being given for your beneficial effects on atherosclerosis. It will also control your blood sugar, but slowly. It will not require frequent estimations of your blood sugar, and it will not produce hypoglycemia, because somehow the time devoted for patient education prior to prescribing Lira is too less for the patient to be convinced that yes, this is the drug.
Thank you, sir. Thank you, sir, for that answer. And I think what is to note over here, what sir has suggested, that the value is more, the benefit is more. Not to have any unrealistic expectations of having glycemic control just immediately. Give it time. It works on ASCVD. So with this, I think I'd like to thank such wonderful lecture. I'd also like to thank all the participants, those who have joined us over here for this even in these times, to reach out to everyone and to spread this education about one molecule which is actually creating waves in be it endocrinology, be it cardiology. So with this, I'd like to thank everyone. Thank you once again, sir, for joining us. Thank you for a wonderful lecture. Thank you all the delegates. Have a good evening, everyone, and stay safe. Thank you, everyone.
Thank you all. Thank you.